So, Dr. Pachter, tell me about your upbringing, your family, and how that shaped you as the person you are today.
And I came to this country when I was 5 years old on a USS troop carrier, the United States USS Taylor. I spent the first 5 years of my life in a displaced persons camp in Europe and arrived here in 1950. And I grew up first on a farm upstate New York and up until the second grade. And then my family moved to Brooklyn. And I went to elementary school in Brooklyn. And then I went to a private high school in Brooklyn, Yeshiva University High School in Brooklyn. But I was interested in basketball. That was my prime interest, basketball and socializing. I was great at basketball at that time. I was the highest scorer on my team. I was the highest rebounder. But I learned a very important lesson from my high school coach, which carried over to my professional career as a doctor, as a surgeon. And my coach called me aside and said, Leon, says, you're the highest scorer on our team. You're the highest rebounder. But let me tell you something. You can be the greatest scorer in the history of the game. You can't score without the ball. So if you don't get along with your teammates, you're not going to get the ball. And this served me well in medicine. Uh, it was only after a trip upstate on the New York State Thruway, where my dad was driving me up for the summer. We had a pit stop at a station on the way on the Thruway, and I noticed that there was a magazine stand, and on the cover there was a surgeon named Franny Moore, who was the head, in surgery in Boston, the Brigham. And I started leafing through this, and then I started looking at this and saying, wait a second, these guys are using their intellectual prowess to then translate into a manual form of curing a patient. And that's kind of appealed to me, using, manual dexterity to cure a patient. And after looking at the various surgeons that they had there, I remember one of them was Mike DeBakey, and I was just blown away by it, by, them showing a picture of him doing a carotid endarterectomy in someone that had a stroke, and then the patient was fine. And I was hooked after that.
But tell me, how did you put it together where you're going to stay in New York, you're going to use the New York systems, NYU and all the like, and build a career that is near legendary?
Well, that was the influence of a legend in surgery, Dr. Frank Cole Spencer. So I was exposed to him as a medical student, and he was just unbelievable. He was just absolutely unbelievable. And then he would lecture us every week as well, and we had the opportunity to be in the operating room. And anybody that was in the presence of such a giant, such a legend in surgery, just couldn't help by being, influenced by that sort of person. So I was hooked on surgery because I really liked the manual part, but I also liked the intellectual part of it as well. And I think that that's something that Dr. Spencer stressed, that the surgeon wasn't somebody who was just cut on the dotted line. Uh, he always used to say you can get as many consultants as you want, but it's up to you to make that final decision. And he tried to create a group of surgeons that were thoughtful, that were not robotic, so to say, pardon the pun, uh, and that they really cared about the patient, and they wanted to achieve technical excellence in the sense that that would help the patient get better. And for me, once I met Frank Spencer, there was no other choice, no other direction that I would ever want to go except to be in surgery.
Let's transition to the role that research has played for you. Obviously, you're most famous for your landmark papers in non-operative management of blunt solid organ injuries and trauma. Tell me how that came about.
Well, when I finished my training, we had no attendings, no full-time attendings for trauma. And Dr. Spencer called me in his office and he said, well, listen, I want you to dedicate yourself to trauma as well as general surgery. The teaching at that time from 1929 on from Coker's textbook of surgery is that the only treatment for a splenic injury was splenectomy, and that you couldn't put sutures into the spleen. Moreover, that the spleen was an organ that you didn't need. And it took from 1929 to 1973 to realize that the spleen was an organ that you really did need, because if you took it out, you'd render yourself susceptible, lifelong susceptibility to infection. So the first time I was in a trauma case with the spleen, I took it out. And then I said to myself, wait a second, why am I taking the spleen out? I think I can save the spleen. So in the next case, that's exactly what I did. I decided to save the spleen. And when I presented this at M&M, I still remember it like it's today. Dr. Spencer said, you did what? And I felt like a bad Shakespearean actor getting pelted with all these rotten fruits. But then again, we started doing this on a routine basis where it was indicated. And then we realized also that not all these spleens from blunt trauma needed to be taken out. So we set up a criteria that we thought was safe for the patient. And in order to do that, you were the person. You couldn't hand that off to someone else. If you were going to go ahead and manage a patient non-operatively, you had to make that decision. You had to examine that patient. I mean, chances were that you were going to get criticized for non-operative and for your innovative approach to not operate on the patient.
You've had so many accolades, so many honors. Which one do you feel is the most important?
Honestly, LD, the most important thing to me was that I wanted equity among my residents and the attendings that I chose. So at one point, I had hired the single largest number of female African American surgeons in the country. For me, that was one of the highlights of my life. And I tell you that because, and I think I'd mentioned to you on the side, is that I'm an immigrant. And as we approached the harbor in New York City, I heard everybody screaming, the Statue of Liberty, the Statue of Liberty. And I got very friendly with the cook on the ship, who was a 6'6" African American guy, great guy, and he hauled me up on his shoulders, and so I could see the Statue of Liberty. And he pointed out to that Statue of Liberty, knowing my background, saying, "See that Statue of Liberty?" He says, "That means that you are free." But I didn't realize, this was 1950, I didn't realize that he wasn't free. The Civil Rights Act wasn't passed till 1964. And he was telling me about my freedom when he didn't really have freedom. And I never forgot that. I never forgot that. And I said that, I'm going to do anything, I'm going to make sure that everyone gets a fair shot at it based on ability. And that's what I did. When I was at Bellevue Hospital, I said I wanted to create the surgical service that would deal with the indigent patient as if they were in a private hospital. I did not want there to be two-tier medicine, at least from surgery was concerned, that there would be one set of criteria for Tisch Hospital at the time and the other set of criteria for Bellevue. In that light, and that's when I recruited Dr. Parikh, one of my residents, in 2007, after his fellowship, to come back, and I wanted him to create the bariatric service for Bellevue to give an opportunity to the indigent patient, the same opportunities that the patients up the street in the private hospital had in terms of weight loss. So we went from 0 cases in 2007 to now we're doing over 3,000. And I felt it was very important to get involved in the indigent population and to provide them with medicine that everybody else was getting. That was number one. The second was that I wanted to hire people based on their ability and not on the color of their skin, but the content of their character. And in that light, I had recruited the single largest number of female surgeons in general surgery in the United States. There are many institutions that will count, neurosurgery, plastic surgery, urology, ENT, but I just focused on general surgery. But when you ask about other things that I was proud of, we had in the entire history of Bellevue Hospital, there had never been 8 chief residents that were all women. And we had one year where all chief residents were women. I think that's another one of the highlights of my career.
Well, let me just highlight this for the audience because I didn't bring it up. Dr. Leon Pachter was honored. He's an honorary member of the Society of Black Academic Surgeons. That's a huge honor and one well deserved. So let me recognize that. If you had to do it again, would you do it the same way? And did you have some preparation for all your leadership roles? You know, everybody these days, Dr. Pachter, are doing leadership roles and going to Harvard for the leadership course. Did you have leadership sort of courses, or did you do this on your own?
I felt that in order to have real credibility as a chairman in surgery, you had to not only talk the talk, but you had to walk the walk. And I know a lot of people that got up and would pontificate about X, Y, and Z, and the comment that would be made, hushed tones, was, well, what does he or she know? They don't operate. They only talk. So I felt that that was really important. And I told the dean that if I took the position, he said, I will not cut back on my clinical activities. I said, I won't, shortchange my educational part, the fundraising part, the administrative part, but I will not cut back on my clinical activities because that's really what gives you credibility as a surgeon.
Talk to me about how you view mentorship in the Department of Surgery and what were your kind of mentorship goals?
I tried to create, in terms of mentorship, a surgeon that was caring, that empathized and sympathized with the patient's suffering and their disease, and felt for the patient. You get all these stories of, oh yeah, the surgeons, they're, heartless. They just operate. They don't really care about the patient. But I think empathy with the patient is an important element of being a surgeon. And maybe some people disagree, say, well, just do the operation. You say, yeah, do this, be nice to the patient, etc. But I think that when you empathize with the patient and sympathize with the patient, you're one with the patient. And I think that that's really important, to being one with the patient. And that's the mentorship that I try to go ahead and project to the younger surgeons. Be one with the patient, be accountable to the patient, never abandon that patient. Don't have somebody, if obviously you can't be there 24/7, but don't abandon the patient to someone else when you could be doing that. I've seen a lot of situations where there were surgeons that were, too busy in office hours and had someone else reoperate on their complications. That's unacceptable. That's not something that I would want to mentor others into.
I think you highlighted, I think you said your trainees and the diversity of your program, but what do you think is your greatest achievement as a surgical outcome?
I think as an educator, I think that when I was a resident, and I actually idolized Dr. Spencer, but the M&Ms were brutal. They were absolutely brutal. I mean, it was like, the attendings and everyone else, it was like, being like a gladiator in the Coliseum. Everybody just took a shot at you. And I said to myself, I have to change that. I want to change the M&M to be educational, evidence-based, and non-punitive. And that's really where I've devoted, my career in education, to change the whole concept of the M&M to be a non-brutal type of thing where everybody took a pot shot at you, but a learning experience, but it had to be evidence-based. Because when I was a resident, someone would get up and say, well, I did this way, I do it this way. It was no data to support that. Absolutely none whatsoever. So I think my greatest contribution is going to be in the field of educating the residents in terms of looking at things from an evidence-based point of view rather than an anecdotal point of view, and the importance of studying the literature and knowing what the data is. You can accomplish something and say, oh yeah, and you want to promulgate that, but your N number is 3. Well, that's not going to get you anywhere. You want to know what the literature says with an N number of 2,000, and then you can come to a conference and say, well, okay, based on this, and this study, which is, a randomized, prospective randomized controlled study, this is what it showed, and this is what we should be doing rather than anecdotal experience.
What should be the anatomy of an M&M conference? Because I know it used to be brutal and all of that, a bloodbath, but what should be the anatomy of a good evidence-based M&M conference?
The anatomy should be as such is that obviously the resident is scrubbed on the case and the attending are both present. The case is then being presented, and then there's an interactive component between the moderator, which is myself, and the audience, calling upon people with expertise in the area, asking them what they would have done at that particular point and why and how they back that up with evidence. Then I throw up the literature, the current literature on the topic. So then it's really evidence-based. And at the end of that, what I've done, LD, is we have this thing called a poll. So I throw up three multiple choice questions. It's anonymous, except for the chief resident that has to answer that. And based on the discussion, they should be able to answer every question correctly. But then the audience has an opportunity to participate. And at the end of that, we ask the chief resident, what's your answer? And the chief resident gives the answer. And then we throw up what the audience said and to see what percentages is. So I found that to be an invaluable teaching tool. And I think that that's really the anatomy of the M&M. It should not be punitive. It should not be a bloodbath, but it should be educational, evidence-based, but at the same time, you should be able to answer a few questions based on the discussion. That keeps everybody on their toes.
One of the knocks we always had on other New York institutions was that death was an acceptable complication for them. And whereas here, I think it probably stemmed from Spencer that we really tried to fight against that with everything we had. We gave everything to our patients. Can you talk about that for a little bit?
Well, that was a culture that Dr. Spencer, really promulgated through all of us, is that yes, you're not going to save everybody, but you cannot step back and say, well, death is an acceptable complication. You did everything in your power to save that patient. You did the heroics. You never give up. And I knew, surgeons that would stand there and continue on when others would have quit, and then the patient survived. And that's something that will never leave me. That philosophy is that you owe it to the patient. Never give up, never give up, never give up.
I wonder how it feels to know that you're the voice that residents hear in their ear when they're doing hard gallbladders or dissecting around the porta or even fixing inguinal hernias. You're the voice that they hear in the back of their minds when they're making tough decisions.
Well, nothing warms my heart as much as former residents calling me up and telling me, well, I was in this situation and I could just hear your voice saying, this is step one, this is step two, this is step three. That means a lot to me. That tree, if you look back at it, one sees it, it's a famous tree itself. It's the tree of life in the Garden of Eden. The residents that put that together then put the leaves on those trees of the 100 or so residents that I trained and that graduated the program. That's something that remains with me forever and touches my heart.
And tell me about your family and their role in your success as a surgeon, chairman, leader in surgery.
Well, I certainly couldn't have gotten anywhere without the support of my wife and my family. They were completely understanding. And I did everything I could for my kids anyway, in terms I never missed a basketball game that they had. I just made it my business to go ahead and do that. And they recognized that I would come home for dinner because I lived across the street, but then had to run right back to the hospital. But the one that I owe the most to is my wife, because without her allowing me to do what I needed to do, I really couldn't have gotten to where I got.
So what are your hobbies? I mean, again, my job is to unveil every part of you, and we're almost done.
My hobbies basically are writing. I write 4 essays a year on world politics. I have a friend in the printing business who ends up putting these into glossies for me. I don't publish them anywhere. I share them with friends, and that's kind of my hobby: word usage in the English language. And writing these essays.
Dr. Pachter, on behalf of the American College of Surgeons and your colleagues and friends, thank you for allowing us to look at the anatomy of a surgery icon.
Thank you so much, LD. There's no other person more than you that I would rather have this interview conducted.